It's estimated that anywhere from 575,000 to 677,000 bloodstream infections occur annually in North America, with approximately 40,000 of those directly linked to patient mortality in the United States, which collectively makes bloodstream infections the 11th most common cause of death in the U.S., according to the CDC. As we all know, the detection of bloodstream infections and subsequent identification of the etiologic agent or agents is an essential role played by all clinical microbiology laboratories day in and day out for routine patient care. So today, we're going to dive into a recently published study in JCM looking at organism-specific bloodstream infection prevalence rates and their individual mortality risks relative to patients with either negative blood cultures and in those for whom blood cultures were not ordered. Welcome to Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter at jclinmicro. This podcast is supported by the American Society for Microbiology, which publishes JCM. And we ask that you please subscribe to the podcast and rate or review it wherever you get your podcasts. I'm your co-host and JCM editor, Ellie Thiel, and of course, I'm joined by JCM editor-in-chief, Dr. Alex McAdam. Hey, Alex, how are you today?
I'm fine. How are you doing, Ellie?
Pretty good.
Good. I'm very excited about this subject. I think it's a great paper you picked, and I'm looking forward to it.
Me too. And I'm also excited because we have two first-time guests for the podcast. Both authors on the paper we'll be talking about, Drs. Nick Daneman and Kevin Brown, who are both joining us from Chile, Canada today. So Dr. Daneman is senior author on the manuscript. He is a clinical scientist in the Division of Infectious Diseases at Sunnybrook Health Sciences Center at the University of Toronto, and he's an adjunct physician at Public Health Ontario. So Dr. Daneman, thank you for joining us today.
Thanks so much for having us. It's great to be here.
And our second guest is Dr. Kevin Brown, who is a scientist at Public Health Ontario and an assistant professor at the University of Toronto. So welcome, Dr. Brown. Happy to have you with us as well. So as I mentioned, Nick and Kevin are both co-authors on a paper entitled Prevalence and Mortality Associated with Bloodstream Organisms, a population-wide retrospective cohort study, again, currently in press at JCM. So to kick us off, I thought we'd start with kind of a general question. And Nick, I'll direct this one to you first, but can you kind of tell us what really led you and your team to undertake this study? And can you talk a little bit about how this study differs from some of the other epi and prevalence studies that have been undertaken in the past looking at bloodstream infections?
Absolutely. Actually, before I speak about the specific study, I realized that I should probably mention first that it's part of a larger research program called Combat AMR. Won't spell out the whole acronym. It's a bit clumsy, the whole sentence, but we like the term, even though it sounds a bit militant. At least we're aggressively targeting this global public health threat. Kevin and I are the co-principal investigators. We're happy to kind of present here today with you all on behalf of a much larger team, which includes lots of terrific colleagues who you'll see as other named authors on that paper, among others, including an internal medicine resident who helped complete the specific study as part of a resident research project, Mark Verwey, who's terrific and can join us today. But we'll soon be applying to an infectious disease fellowship program somewhere, so if he applies to yours out there, you should definitely accept him. It's great. But in terms of the specific study, we really wanted to provide population-based surveillance of bloodstream infections, across the jurisdiction, because most surveillance that's done as part of active surveillance networks, these networks are really important, but they're labor-intensive, costly, there's large time lags, they require active coordination, numerous sentinel hospitals voluntarily collecting isolates and contributing to some central reference laboratory where very rigorous standardized testing can be undertaken. And we think that's important, but the problem is it is associated with selection bias, right? You're going to be focusing on academic tertiary care centers, missing out on smaller community hospitals, missing out on infections acquired in the community, and non-institutionalized populations. So what we're trying to harness is all of this routine microbiology data collected every day as part of routine specimens around the many microbiology laboratories in a jurisdiction, and it just sits there like gold, unused, and it can be used to answer so many important questions. So we were able to tap in Ontario on the Ontario Laboratory Information System, OLIS, which accumulates all microbiology data now from all of Ontario's more than 100 contributing laboratories. And we've had the good fortune that that's now linked in to our ICS, formerly called Institute for Clinical Value Sciences, that links administrative data across the province. All of a sudden, we're able to get access to population-wide microbiology data. So we want to take that and show the power of using routine data. Maybe not as standardized, but a wealth of information in there. So this is an example of how in just 1 year of data, we can access 500,000 blood cultures, 250,000 blood culture episodes, and 23,000 or so positive blood culture episodes, and answer some interesting questions.
Yeah, it sounds like it's really a massive amount of data that you guys are able to look through, and this is probably just one of many questions that you can ask and use that data to investigate. So kind of with that background, Kevin, do you want to take a stab at summarizing your study design and the approach you took to look at prevalence and mortality rates associated with bloodstream infections?
Yeah. So it's a cohort study design, which means that we use data from OLIS, which is the Ontario Lab Information System, on blood cultures. And so one of the first steps was really to actually clean these data that were coming from many different healthcare centers that wasn't necessarily perfectly standardized. And so we were able to clean the data from across all of these different hospital, community, and public health labs, and combine that into one data set. And so we identified everybody that had a positive blood culture in OLIS over that time period. And then we were able to follow those people to look at outcomes. We also had a layer that was like a multivariate analysis, where we are able to use that to compare people that had positive blood cultures to people that had negative blood cultures, as well as to people without any blood culture at all. So we had two different control groups, people with negative blood cultures and people without any blood cultures at all, because we know that people that receive blood cultures in the first place are at quite a bit higher a risk of having severe outcomes, because they're people that are sicker than your average person in the population. And then we follow those people for 30, 90, and 365 days after that positive blood culture to see whether those people died in that time period.
Yeah, so I think that's one thing I really liked about your study is the length of time you followed these patients. Can you kind of define, so one of the things you guys use in your study a lot is episodes. So can you define what the bloodstream episode is, since we're going to be talking a lot about that relative to outcomes?
Yeah, Nick, do you want to actually pipe in and kind of explain how we came up with the episodes?
Sure. We are trying to strike a balance where we want to capture all positive bloodstream infections that are separate. We don't want to limit to just one unique episode for a patient, because a patient could have had multiple different bloodstream infections in the course of a year. But we also don't want to overcount if one episode has multiple episodes. For example, if someone comes into hospital, has 3 blood cultures sent, all growing E. coli on the same day, those are likely part of the same infection. So there's no perfect time window definition. There's going to be trade-offs the longer you make that episode definition versus the shorter. But we opted for 7 days, feeling that blood cultures collected within the same 7 days are highly likely to be part of the same infection. And after that, going to be less and less likely over time to be part of the same infection. So in the end, there were 23,000 or so, just under that, blood culture episodes that were positive in the study among 19,000 patients. So you can see how there's slightly more episodes in patients because some will suffer from more than one.
So the clock starts ticking when the first blood culture is collected. Out 7 days, that's one episode. If they then get another blood culture on day 8, that's the beginning of a new episode, potentially. Do I have it right?
Although if it was the same, or if they then get within 7 days of the last positive, we would still scoop it in with that episode.
Got it.
As well.
Got it.
Got it.
Thank you.
And then the last question I have with respect to methods is contaminants. How did you deal with potential contaminants in your study?
Yeah, that was debated among the team along the way. One option would have been to leave them out altogether, right? Because you can be less certain that a positive blood culture is real and important when it has one of these common contaminant organisms like Staphylococcus epidermidis or Cutibacterium, Micrococcus, etc. But we did feel it was one of the strengths of our study that we had the ability to access all positive cultures and didn't want to lose out on that. So in the end, we just required 2 positives to make it a bit more stringent. And that's in line with prior research. In studies where there's access to bedside clinical data, they'll often add an even more stringent criterion where patients have to have had some clinical signs of infection to accompany that, but we don't have access to that in the administrative data.
Got it. So I guess starting to dive into to some of your data, you identified an overall incidence rate of about 150 bloodstream infection episodes per 100,000 population or individuals. I'm just wondering if you or Kevin can comment on how that compares to some of the previous incidence rates that have been described. Is it about consistent with what we've seen in the past? Is it higher? What are your thoughts?
Yeah, it feels very consistent. As I was saying before, most studies in bloodstream infection surveillance are based on these sentinel networks. They aren't population-based, and so they can't speak to a denominator and can't report out on rates. So we can't compare to the vast majority to get that information, but there are a handful of excellent population-based studies out there. They tend to be in smaller regions. We have the benefit of having this population of 14 million people in a universal healthcare system, where we have a huge area and a huge population, a huge denominator. But there are others in the smaller regions which have been able to do the same thing. So in Olmsted, Minnesota, Mayo, you're probably aware of that one from a while ago. There's another one in Calgary Health Region in Alberta, and a few in Scandinavian countries. And looking through them, the rates per 100,000 population tend to be anywhere from about 80s to low 200s. So we fall right in line with that, which is encouraging. I think it adds face validity to our results and makes us feel confident that this, what we think is an innovative approach of harnessing linked data from hundreds of different labs, can get you towards the truth.
I have a very basic question. A lot of the audience is clinical microbiologists, and they may be less familiar with what population-based means. In this context, does it simply mean that because your medical system is providing all the care within the region, that you can be confident that you're capturing all the medical care that occurs, so you can describe the entire population? Is that a fair summary?
Yeah, that's a perfect description of it.
All right, so getting into the nitty gritty really of your findings. So again, you looked at blood culture episodes and positivity rates relative to various different demographic factors like age, sex, hospitalization length, and where the blood culture draw actually occurred, which I thought was interesting as well. So I guess, Kevin, do you want to summarize kind of what jumped out at you guys? What was really surprising or consistent with what you've seen before?
I think that there were a few different kind of primary findings. One is that if you use a test negative design, we ended up seeing much lower kind of attributable risks associated with positive blood cultures. That's because what we found out, because we used 2 different control groups, both the test negative control group, so negative blood cultures, as well as a comparable population control group that didn't actually have a negative test. we were able to kind of compare those results and show that, sure enough, the attributable mortality associated with a positive blood culture was much higher when you're looking at population controls that didn't have negative tests. That would be one of the primary findings. Another is that there's a wide distribution of mortality rates associated with bacteria. E. coli infections were not particularly severe, but they're by far the most common infections, whereas a few bacteria had by far the highest case fatality rates, like Clostridium species infections.
So maybe taking a little bit of a step back, I guess I'm wondering if you can kind of talk a little bit about what you saw relative to blood culture positivity rates for the demographics that you were looking at. I think one thing that jumped out at me in particular was that it seemed like a third of your blood draws occurred in kind of the community setting, yet they were associated with the lowest positivity rate. So I'm just wondering, do you think that there would be some opportunity for optimization or education, perhaps at those locations, given the kind of fairly or lower blood culture positivity rates? I mean, obviously we don't want to miss blood cultures, but it seemed like the rate of positivity versus the number of blood draws was quite different than some of the other healthcare locations where blood draws are routinely performed.
Yeah, that would make for a neat follow-up study to focus on the community blood draws, because it is an advantage of this methodology and the fact that we're able to identify every single blood culture drawn in the entire province, that we're able to identify these ones drawn in the community, whereas almost all other research would be limited to draws, specimen collection in acute care. Even the community-acquired bloodstream infections are typically, the ones that diagnosed on admission to hospital from the emergency room as people arrive. So kind of need to be able to focus in on these tens and tens of thousands of ones drawn on people that actually never get admitted to facilities. It's true they had they were the most numerous, but the lowest yield in terms of positivity. So a potential role in identifying risk factors for positive versus negative cultures in those community specimen collections, and then a knowledge translation activity to try to minimize overculturing.
Anything else that kind of jumped out from the demographic association with bloodstream infections?
No huge surprises. There were some trends, things like as you move to acute care and then to ICU, more candidal infections, more enterococcal infections. Among women compared to men, more E. coli infections and less Staph aureus infections. But none were that dramatic. If anything, looking at the graphs in Figure 2, which summarize across demographics, the first thing I noticed is that you see the same bugs in people's bloodstreams across all of these demographics, just in slightly differing proportions. So the trends were probably less striking than I would have anticipated, based on the major kind of demographic characteristics of interest.
Got it. So one of the other focuses that you guys really looked at, and I thought you did very nicely, was looking at the mortality rate. And from your study, you basically found about a 17% mortality rate in your patient cohort at 30 days, compared to only about, I think, a 9% mortality rate amongst culture negative patients. And then you really dived in and looked at organism-specific mortality rates. So I was wondering if you guys could kind of take us through that. So what did you really find on the individual pathogen level with respect to mortality rates? Which ones should we be most worried about?
Yeah, we did try. That was one of the things we did really try to do, is dive in, like you said, and be very, very granular. Because in the active surveillance networks out there that take so much work, because of that, we often have to drill down and decide we're going to focus in on just these top 5 pathogens of interest or top 10 pathogens of interest, but we have the ability to look at all of them. So I think our tables end up down to 82 pathogens, and we ended up cutting it off at some point just for, be able to fit displays into a manuscript, into the journal, but could go even to smaller, less common organisms as well. And so we feel like one helpful deliverable from this is to be able to provide that crude mortality rate at 7 days, 30 days, 90 days, 365 days for each of those pathogens. So the clinicians out there or researchers with a specific interest in any one particular pathogen or group would have a reference table where they can go to and have a sense of what the overall risk of death is at different time points for those pathogens.
Yes. So you looked at, you list, right, the pathogens associated with the largest number of deaths versus those are associated with the highest crude mortality rates, and they differ quite dramatically, right? So do you want to kind of talk a little bit about which kind of the different pathogens that fall in those two groups?
Yeah, in terms of total deaths would be a factor of both the attributable mortality and also just the sheer number of infections. But in terms of attributable mortality, which is what required that hard work of comparing to patients with negative blood cultures or patients matched patients in Ontario without bloodstream infection, there were some that really stand out. So Clostridium species with the highest increased odds of mortality compared to somebody with a negative culture or no infection. Other ones which stood out, Staph aureus, among the Streptococci, group A, Streptococcus. Outside of bacteria, to not forget Candida, which is a common cause of bloodstream infection and a very high attributable mortality were some of the ones that stood out when comparing. And this is after accounting for quite a range of important potential confounders: age, sex, the place you were when that culture was taken, so community, long-term care, acute care, or ICU, and the number of days you were in hospital in the last 90 days, and your burden of comorbidity by the Charlson Comorbidity Score. So even after accounting for all that, those organisms still look to be predictive of death compared to others.
Yeah.
Can I follow up on that? Because I was quite struck by the finding with Clostridium, and social media was too. A lot of people tweeted your paper, including that terrific figure in the paper, and people were commenting on the fact that Clostridium stands out for having a very high mortality association. How can you? So it's an association. Is it? Do you think causal, or could that high mortality associated with Clostridium be reflective of gastrointestinal pathology that may actually be leading to death? How closely can we link these things causally? It's a tough question, I know.
Yeah, no, that's a way to word it. I mean, one thing we haven't measured or accounted for in this study, but will in future work, is the source of infection.
Mm.
So you kind of alluded to it. For Clostridium, the most important would be intra-abdominal pathology, like a surgical or other abdominal catastrophic event. And so it is a high adjusted risk of death with Clostridium just because we're finding it as a marker in the blood in somebody who's had one of those events. And you're right that could be contributing to that high adjusted risk of death. It still means, though, that if we find Clostridium in the blood, we know that patient is at a very elevated incremental risk of death.
Yep.
Compared to not finding it. Whether it's that organism and its specific virulence factors that are causal versus the infection pathogenesis that led to it getting into the blood, it will be a combination of those that might differ by pathogen.
Thank you.
I think one of the other things that you guys looked into that was interesting was breaking apart the Corynebacterium species and looking at mortality associated with some of the species that have been, I guess, defined to have higher pathogenicity. So do you want to talk a little bit about whether you found any differences in mortality within the genus, Kevin or Nick?
we do owe your reviewers of JCM for asking us to push a little bit harder on that. And they did request some species-specific looks, which we then provided in as an added kind of post hoc information into the manuscript. The reason they asked for it is that Corynebacterium species are among that list of potential contaminants that we talked about earlier. And so we would expect that most of the potential contaminants would have an odds ratio for death close to 1, no incremental risk compared to a patient with negative bug cultures. And we did find that for most of the contaminant species, like Bacillus species and others. So we took that to mean that there's strong face validity to our methods. But Corynebacterium species was one that didn't really follow that rule and had a high adjusted risk of death. So the reviewers asked us, can you look at, is it maybe because some of them are these species of Corynebacteria that have been associated with severe disease, like JKM and striatum. But when we looked, we still saw in that subset versus other species similar mortality, so it didn't really explain that finding.
Got it.
One possibility is residual confounding. We've adjusted for a lot of important factors, but there could be some significant confounding left behind. So we adjust for the fact that they're in ICU, but 2 ICU patients might not be exactly the same. One could have more devices, more central lines, be on a ventilator versus not on a ventilator. And some of those kind of things could predispose to a Corynebacterium positive result, especially the many lines. And we adjust for Charleston comorbidity burden, but we don't adjust for individual comorbidities like cancer. And perhaps, patients with cancer and central lines, Porter-Cass-Hickman lines could be at greater risk for Corynebacterium species.
Got it. Thank you. So I think, it's pretty apparent, right, that Staph aureus really stood out as one of the most burdensome bloodstream infection pathogens. So I'm just curious if you're aware of any innovations or thoughts going forward on how to kind of help address the Staph aureus problem.
We call for vaccination as something to think about in the pipeline, but I'm not aware of major advances there, although there could be. The main one I'm aware of would be around treatment, because even though Staph aureus is, like you can see, one of the most burdensome causes of bloodstream infection in the world, there have only been a small number of randomized controlled trials comparing treatments involving only less than a few thousand patients all put together. So pretty excited that the Staphylococcus aureus Network Adaptive Platform Trial called SNAP has just launched. It's led by Josh Davis and Steve Tong in New South Wales and Melbourne, Australia. It's going to enroll several thousand patients. We're participating in Canada. The UK is participating. New Zealand is participating. And it's going to ask a number of core questions around care. It's going to randomize people to different backbone antibiotics. For example, cefazolin versus clostridium for methicillin-sensitive Staph aureus, different regimens for the backbone for MRSA and penicillin-sensitive Staph aureus. They'll all be randomized to adjunctive clindamycin or not, and they'll all be randomized to oral step-down versus full course treatment with intravenous. So able to answer those 3 major important questions at the same time with lots of neat mechanistic sub-studies overlaid on top of that. So it will take some years to do, but I think it is going to move the needle forward in terms of optimizing care for those patients. Even better, we could prevent those infections. So it'd be good to hear some innovations in that respect.
Awesome. Thank you for that. So I want to thank Nick and Kevin for joining us today and talking us through your study. And we will see you and the listeners and the viewers for next month's episode in Editors in Conversation. Thank you for joining us.
Thanks so much for having us.